This is Dr. Elzo Pereira Pinto Jr. He's a postdoctoral fellow in epidemiology at CDAX in Brazil. He's currently focusing research very much in partnership with IDM and some of our IDM colleagues in the areas of primary health and health outcomes. So I'll hand it over to you.
Hi everyone, good afternoon. As my previous colleague, I'm also not a modeler or a statistician. I'm an epidemiologist, and my presentation will cover some topics about primary health care. And my main background is evaluation of health policies in Brazil, basically primary health care, and how this kind of intervention, this huge intervention inside the health system, can influence the under 5 mortality and other outcomes. But the work that I will present here today will be about the evaluating the quality of maternal and child health services in Brazil and in Brazilian primary health care, and we will present a very interesting approach that can dialogue a lot with policymakers, because the nature of the results that you can present, that is latent transition analysis. So before I move to my presentation and giving more details about the primary health care in Brazil and our evaluation, I will make a brief presentation about the place we are working, that is CDAX, and an overview about what means primary health care in the Brazilian health system, and also some challenges that we have to face to measure primary health care quality, and finally detail the process to evaluate the quality of maternal and child health services in Brazil, and bring some final recommendations about this. So I'm from CDAX. CDAX is a research center that used the huge data sets in Brazil. Brazil has an amazing data ecosystem that plug data from social indicators, social economic indicators, and social policies with data on health. Using different methodologies, we developed a specific record linkage algorithm to make this, because in the unified health system, in the system in Brazil, we didn't have a unique identifier that allows to link this one. We are recently, only 7-8 years since our foundations, and 2 of our main products are the Brazilian cohort. The first one is the 100 million Brazilian cohort that currently have 143 million of Brazilian. The idea of this cohort is based on a huge data set on unified register from social and demographic informations. We add different other data sources and create the possibility to explore in a longitudinal way the effect of social determinants, the effect of social policies, and on different outcomes. And we have a more specific cohort that we call CDAX live birth cohort that is quite similar with the previous one, but has a main characteristics that is more related to investigate early life exposures and determinants and on birth informations, and how this first cycle of life can influence in other life cycle. So and based on these 2 main cohorts, and based on the data we have in Brazil and on these cohorts, we can explore in our analysis a long list of exposures and interventions, and also a long list of health outcomes. So what we are presenting is like this square here, the relationship between health services and maternal, neonatal, and child health. But as you can see, we are exploring different areas, and more recently we add a layer of environmental and climate data to also explore the effect of climate change on different outcomes. So, but my main aim here today is to present what we are doing at this research group. We have a research group that we call CDAX PHC. The main aim is to evaluate the effect of primary health care on population health, and is funded by the Bill and Melinda Gates Foundation. So, just a brief review about primary health care in Brazil. The Brazilian unified health system is built on some principles of universality, equity, integrality, and every Brazilian citizen, or even some foreign, can have access to hospital care, specialized care in primary health care. But primary healthcare is the core of the health system because they are responsible to represent the first contact between the people and the health system, and also provide a broad range of services such as the classical ambulatory care, but also promote health activities, prevent diseases, offer consultations, vaccination, surveillance, and home visits. We have physicians, nurses, community health workers, and dentistry compose these minimal health teams. And from the most recent data that we have around 50,000 of PC facilities with million of health workers in Brazil. So this specific product aims to evaluate the adequacy of maternal and child health services in PAC using quality standards based on a normative approach. We didn't use a machine learning approach to create the indicator that we produced, but a normative approach. And we examine changes over 8 years using these methods that we will present about latent transition analysis. So for this, we used, in this study specific, in this part of the study, we didn't use the linkage with the 100 million cohort, but in order we are exploring this. This study was based on a big survey that was produced in Brazil. That was also at the same time a big survey of quality and also pay for performance program. And they capture information about structural adequacy of healthy units and also a different characteristics of provided care by the health professionals. We can see that over the 3 cycles, the 3 rounds of PMAC, we have an increase in terms of the coverage of health teams evaluated. So we have a lot of main changes to carry out this analysis. One first main change was try harmonize the data that we have across the 3 cycles. It wasn't the same questionnaire. We have a lot of difficulty to do this. But before the review of the questionnaire, it was also a big challenge to try identify what health facilities had the same amount of health teams that we can guarantee that a similar team was evaluated around the 3 cycles. And then our evaluation is related to 8,776 health professionals teams at primary health care. So, but this was the big challenge that we faced to do this, because we need, like screening, a big survey with, I think that more than 1,000 variables, to identify which informations remained in all the 3 rounds. And when we evaluate the combination of these variables, we have 4 possibilities. Some variables and indicators were perfectly compatible, so we can use easily. And some have closed questions, but have different answer options. So take some decisions about how to incorporate this one. More challenging was some variables had a different word of the questions, and a double check if are asking the same questions to include and have a same metrics. And in some cases, very good, very important variables unhappily were not available in both round 2 or 3. And after a long journey to try to refine this, we also reviewed this framework, reviewed these components using 2 approaches. The first one was what is more usual, a research working group. We spend a full days, a week working on the indicators. But what is most important for us is invite health professionals from primary health care, policymakers, stakeholders at different levels to support our final decisions regarding what is the main questions that need maintained to guarantee that we capture the quality components on maternal and child health. So this is the final list of indicators that we have. We have a group of antenatal and postpartum components that includes information about prenatal exams and syphilis treatment or strategies for postpartum care. We also have a second group of indicators about child care that include surveillance activities, community outreach, and recording for the child follow-up. And we also have a third group of immunization. In our case, we don't capture if the child received or not received the vaccine. We capture the information about infrastructure and availability of vaccines, and also cold chain supply. The first result descriptive that we have here, as you can see, you can perceive an increase in the performance of adequacy of a long list, this list of antenatal and postpartum care indicators. We also saw a good improvement in the child care indicators, but we don't have so many improvements in the infrastructure for immunization over the time. So some indicators with a huge improvement like prenatal exams and syphilis treatment offered, and also record for pregnant woman follow-up, and also a good increase in surveillance activities for child health care. So then the next challenge was try capture all these changes over the time. What we are trying to do this dynamism. We are calling this as dynamism. I will try to give some general idea about this. We use the latent transition analysis that is an extension to latent class analysis. And why you use this? Because these methods help us to understand this dynamic process and capture and measure the pattern of change in characteristics on behaviors that are not directly observable. We have indicators, but the main component was a latent variable. So we capture in this method the probability of transition among different patterns, which means what is the probability to transition from a low quality to a high quality pattern. And we have some assumptions that measure of the same behaviors patterns of the time, and individuals can be moved between these patterns. So just a step by step of this method. In the first phase, we need to use that more latent class analysis to identify and characterize these quality patterns. And after we estimate the prevalence of each pattern of quality across the time, and finally we capture these transitions, the dynamics between these latent states over the time. So this is the first part of results that help us to understand what means most adequacy and what means least adequacy in terms of the quality in maternal and child health. As you can see here, when we are calling most adequacy health teams, represents a team with a high probability to have adequacy in all the indicators that we are evaluating. So when you are calling a team classified this as most adequacy, it represents the team that have the better performance in all indicators that we calculated. So, and the main result of our latent transition analysis is this picture. At this picture, you can see the prevalence of these latent states at time 1. For example, here we saw that only around 30% of health teams were classified in the most adequacy, and in opposite, 70% was classified on least adequacy in the first round of the data, the survey. We can then estimate what is the probability to this amount of health facility teams keep in the same status, latent status, that was 66%, and 33.9% had a probability to decrease, to worsen in terms of the quality. On the other hand, from that health facility, the health teams that were classified as least adequacy, we saw an improvement, a probability that 27% of these health teams improved to the most adequacy in the round 2. In the round 2, we have 38% of teams classified as most adequacy and 61 classified in least adequacy. And we also can estimate what is the probability of this amount of health teams keep on the same latent status or worsening in this case. Then we can see that once that they achieve the most adequacy, it's so low the probability of they reduce compared to the time 2 to time 3. On the other hand, at the time 2, from this 61% of health teams that were classified on least adequacy, 8% has the probability to increase, to improve hair quality over the time, and only 90% and have the probability to keep in the same latent status at the end. So what we find on based on this data, what our findings. And over the 3 PMAC rounds, Brazilian primary healthcare teams experienced a remarkable improvement in the quality of maternal and child healthcare components. And over the time, the teams initially classified within the least adequacy group had a substantially higher probability of transitioning to the most adequacy category, especially between the round 2 and round 3, indicate a significant improvement in this component of a Brazilian primary healthcare system between 2011 and 2018. We have 2 hypotheses to explain these results. The first one is the evaluation process encouraged by the survey that was at the same time pay for performance, and also motivate the self-evaluation of the health teams, can be considered an inducer of improvements in process, and because they spell out what should be done based on the form they show to the health facilities, they show to the health teams what should be done to cover each one of these components of maternal and child care. And these results also indicate a substantial improvement in the quality of the teams that have participated in this program since these creations. And finally, some recommendations. We in this first results, we present an overview of the whole Brazil, but we are goes in a more specific analysis to identify regions or populations where improvement have lagged and implemented target policies to reduce disparities in access and quality of PC services. This is a kind of tool because after the end of all this process, we are producing a tool that can be used to keep evaluating these indicators over the time, and it can improve real-time monitoring and feedback loops, and allowing teams to track their progress. The program was discontinued, but the survey, the questionnaire can be used for new initiatives to monitoring. And it also highlights the necessity to implement continuous professional development programs focus on this process of quality improvement in terms of primary healthcare services. So, as I mentioned before, we have a huge team that's dealing with all these questions. We have my colleague Valentina that's here, but we also have a team from statisticians, people from public health background, and also some people that had a background in epidemiology. I think that's it. Thank you very much.
Thank you very much, Elsa. Any questions from the audience? Oh, yes. Kari.
Thank you. Congratulations. I've been following your pay for performance strategies in Brazil, and they're very interesting. Just something I didn't understand. Who was answering the questionnaires? The same teams, the same healthcare teams? It just in case if there was some possibility of bias, in each quality study, if the same people that provide the services are going to be assessed in their quality, perhaps the possibility of overrating and saying that they are doing much better, and perhaps that might be different if the people that use the healthcare service provide the answer. I don't know.
So the answers are done by the health professionals. So we try capturing the health teams that have a similar composition during all the process. So we are try guarantee that the same. We cannot guarantee 100% that the people that is exactly the same, but at least we are try guarantee that the same health facilities and the same health teams were evaluated around the 3 rounds. It poses us an additional challenge that was we need to reduce the amount of data that we have to evaluate, because in some cases when we have huge health facilities, for example, it can imply in different health teams evaluated across the different timelines. So we choose the lowest one to try capturing a similar team that was evaluated over the 3 cycles. So, and again, this is a problem when we are using quality evaluation of quality of primary care that is not based on the user perception, is not based on the people that goes to services, is based on a normative approach that uses to capture the information from who provides the care.
So it's like an auto report of quality. You have the mic.
It's the people answering the questionnaire are the health professionals, normally a manager of the health team, a nurse, normally this kind of profile. But the people asking the questions, so filling out the questionnaire, and in theory verifying what they're, what they're evaluating, were teams from academic institutions. So the Ministry of Health contracted as kind of a third party. Some academic institutions have formed a consortium of over 40 institutions that were managed by like some leading ones, but across the whole country was like about more than 40 institutions. So they formed teams and trained them to go and ask. They together with the Ministry of Health, developed the questionnaire, and then they were the ones that went to the field to implement it. That said, we did see, there are anecdotal reports of what in Brazil they call pemaquiagem, that is kind of putting the PMAC makeup on, meaning that there are reports of like, municipality bringing items that were being evaluated from one facility to another, as day by day, each were visited by the team that was evaluating. So, but this happens in pay-for performance. We know that it happens and there's ways to like curb it, but we don't believe that it would really affect the data, because a lot of the literature that studies the quality measured with this survey has reported generally improving quality across the board.
So it's not only because it was self-responded by the health professional that everyone say that was everything good. We have, as you can saw in some presentations, we have declined, and even for very basic items that we have on the survey, we have a lower adequacy in a lot of that one. So even that with this, we consider that this survey could capture like a good picture about what is happening in primary healthcare in Brazil.
So my first question is really about the process you went at the beginning, where you sort of had to select indicators, and I thought it was really great to have stakeholder involvement in part of that. And I'm just curious, out of that process, were there any discussions about where the stakeholders said, these are the indicators we really want, and they've never been collected, and we're just missing something entirely?
So it was expected when we invited the stakeholders to discuss with us regarding what will be on the final version of our evaluation tool. And what we always said is, even that we cannot incorporate this specific indicator that we are asking for, because we are using secondary data, we are making a reuse of the data, we will take into consideration in our reflections about the interpretations, the limitation that have when we did not include this kind of data. So this was a very interesting topic. We have a full day of workshop with this group from different backgrounds, since the community health workers to the representative from the Minister of Health in terms of childcare at Primary Healthcare Secretariat, and bring a lot of different ideas how to deal with the data. And also we need assume, recognize the limitations that don't have a primary data collected.
Any last questions before we close this session? No. All right, let's give a round of applause to all of our speakers. Thank you so much. Very, very interesting. I will volunteer them to follow up by email.